Good afternoon. Apologies for the slight technical hitch, or rather my incompetence in not switching the microphone on. Welcome to today's meeting of the Health and Wellbeing Board at the London Borough of Hillingdon, and this meeting is being broadcast on the Council's YouTube channel, Hillingdon London. My name is Keith Spencer. I'm the Managing Director of Hillingdon Health and Care Partners and the co-chair of this board with Councillor Jane Palmer. So before we start, as usual, we've got some important housekeeping for everyone. Please ensure any mobile phones around you are on silent. We do not expect a fire drill, so if the fire alarm does go off, please follow officers out of the building. Unlike myself, please keep your microphone muted when you're not speaking, and then unmute to speak. So we'll now move on to the agenda. Apologies for absence. Nikki, do we have any apologies?
Chair, we've had apologies from Kelly O'Neill, Richard Ellis, Tricia Wright and Councillor O'Brien.
And thank you. And can I add to that, Sean Bidwell? Sean has gone down with COVID, so won't be here presenting on behalf of Gary. So we'll pick that up when we get to the relevant agenda. Declarations of interest in matters before this meeting. So other than those already declared on the register of interest, do any members present have any declarations of interest on any matters being discussed this afternoon? No. Thank you very much. So if we can now move on to minutes of the meeting on the 30th of July. I hadn't realised it was only so recent, the last meeting. I wonder what intervenes to make that one so late. So does anyone have any comments on the accuracy of the minutes? I'm getting shakes of the head, which I'm taking as assent. So if not, are these agreed? Thank you. So, exclusion of press and public. If I can move on rapidly, I can confirm that items 5 to 7 will be considered in public, and items 8 to 9 will be considered in the private part of the meeting. Okay. So what I'm going to do now is move on to the first item on the agenda, number 5, agenda item B, the Hillingdon Joint Health and Wellbeing Strategy Update, for which I'm delighted that Sheikha, you're here to present on behalf of Kelly. So can I hand over to you, and rapidly switching my microphone off. So can I say we just have a slight technical problem with Sheikha's mic, so bear with me for 1 minute.
Hello, can you hear? Hi. Yeah. So, Director of Public Health, Kelly O'Neill, has prepared this report, and I'm presenting this on her behalf. So Hillingdon Joint Health and Wellbeing Strategy in its second year currently. So Kelly has attempted to report on, this is the interim report on the progress for the second year. Planning and implementation progress of health inequalities funded projects is also within this report. And she's also requested that the Joint Health and Wellbeing Strategy 3-year cycle will end in 2025. And she's requested that the board delegates the responsibility to Director of Public Health, Kelly O'Neill, to develop the new strategy. And the timetable of that strategy will be concurrent with the updating of the Joint Strategic Needs Assessment, which is also underway. And also there will be a consultation period involving the views of and engagement from the Hillingdon professionals, residents, neighbourhood and community groups across the borough at different stages of strategy development that brings insights and understanding to how we prioritize for the next 3 years and how we tackle those priorities. The Year 2 interim report is planned to be presented in January 2025. As you will see throughout this report, the data for this year is not available, and we are hoping that we will have at least some of the information available to help us evaluate how year 2 has gone, year 1 and 2 have gone with respect to this strategy. And the combined year 3 final report that includes strategy closure will also be presented to the with the new health and wellbeing strategy in September 2025. So that's the ask from Health and Wellbeing Board. So as I said earlier, so the current report, which is in front of you, apologies about late circulation of this. So this briefly summarizes the progress and achievements against priorities which were agreed, and the context is that there were 6 priorities under the current joint local health and wellbeing strategy, which are in front of you on page 1 and page 2. I won't read each one of these, but they go across the life goals. So it starts with children and young people, and with support to children and adults to live well, independently, and for longer, in older age. It also tackles mental health services through prevention and self-management, and improve the way we work within and across the organizations to offer better health and social care. And then the strategy is delivered through 6 enabling work streams, which are neighborhood-based preventative, proactive care, urgent and emergency care, end-of-life care, planned care, care and support for children and young people, care and support for people with mental health challenges. The following section demonstrates the reported progress and improvement that is being achieved between year 1 and year 2. So each table, which starts from page 3, focuses on the priorities stated in the strategy, and where available, the data is provided based on the KPIs that are responsible, that the responsible officers and aligned groups use to monitor the progress on the strategic objectives. The RAG status is based on national benchmarking using published thresholds when this data is available. When a national benchmark is not available and a local assessment has been used, the priority has been marked with asterisks. This information will be updated in the end of year 2 evaluation report, which will be presented to Health and Wellbeing Board at a meeting within 24-25, between January and March, I believe. So if you like, I can take you through priority by priority. Is that, I don't know how long I have on this. Is that okay if I...
What I would assume, Sheikha, is that people have read the paper, so a summary would be helpful rather than a line by line read through, if that is okay with you.
Yes, Chair, that's absolutely fine. So I'll try to go through it as quickly as possible. So on priority 1, which is providing support for children, young people and their families to have the best start and to live healthier lives, the very first priority is tackling overweight and obesity in children. I'm pleased to say that although this indicator has been RAG rated red, and for the year 2 amber, we have made progress, and I've just checked the 22-23 data, which is not represented here, where we've seen a further drop in obesity rate for reception year at least, which is at 19.4% and has significantly improved against England. And this was rated amber all because Hillingdon hadn't improved for year 6 as well. So that's the reason why it's rated amber. And some of the combined action on improving oral health of children is also the same actions, because the risk factors for obesity and for oral health are similar. It's about improving diets, improving the environment in which children grow up. So, for example, starting from early years, some of the action has been around reducing the availability of fizzy drinks and sugary drinks to children, which benefits children's health across the board, and also promoting breastfeeding, increasing the prevalence of breastfeeding in the borough. Data shows a drop. However, the strategy is being reviewed, and because breastfeeding is a high-impact public health intervention, which not only benefits the nutrition, but also social, emotional health, and also dental health as well. So we want to ensure that we get it right. So the strategy will be reviewed, and we are hoping to complete a breastfeeding and infant feeding needs assessment with Hillingdon Hospital early years services and 0 to 19 services, and also review what intervention is being given to parents, the breastfeeding education and initiation support given to young mums. That's going to be reviewed as well. So this is a high priority. And on oral health also, we are enhancing the availability of supervised toothbrushing. In the past, the availability of supervised toothbrushing program to schools, implementation in schools, has been a bit patchy. But now, with the help of NHS inequalities funding to provide extra support, we are implementing a program starting at even earlier age in nurseries. So in addition to that, Brush for Life will be increased as well. The ambition is to make Brush for Life available to all babies born in Hillingdon. There are odd 3,900 to 4,000 children born every year, and all of them should have a Brush for Life pack, plus the intervention for parents to start toothbrushing from an early age. Moving on to smoking. So this is green due to sustained low prevalence amongst the 3 priority target groups compared with London and England. So we are doing well, but there are still far too many smokers in our population. 12.7%, that's the latest data, of 12.7% of adults smoke in Hillingdon. And therefore, we are in the process of implementing the Tobacco Control Plan 2022-25, which was ratified by Health and Wellbeing Board in June 2023, and it sets out a shared ambition for a smoke-free borough by 2030. Now, there has been additional funding as well, which is being applied for Stop to Start and also Swap to Stop. Swap to Stop is for investing into a new vaping program, which was a successful bid to DHSC for vaping equipment as a harm reduction intervention for those who already smoke, to reduce harm for them, and an additional Stop to Start strategy. And we cannot undermine the vaping, so let's not forget that. So there will be action under that to reduce the use of vaping among young people as well. So all of that work is underway. Again, on children and young people, we've consolidated the integration of therapy services for children and young people, and to redirect resources into early intervention. So the contract for children's integrated therapy service has been collaboratively procured with CNWL as part of 0 to 19 contract, and there are areas of this contract that have not been agreed, but work is underway. This is rated amber due to collaboration agreement through which the contract has been awarded, being early in its implementation, and there are contractual issues which are being progressed. Hillingdon Domestic Violence Abuse advocacy service on the next page. So this service has made significant progress in the recent year. Since June 2022, the abuse provision has domestic abuse provision has evolved and is now known as HDAS. It's more robust and has grown in capacity. The key things that I would like to highlight are that the service now consists of IDVA, which is Independent Domestic Violence Advocates for High-Risk Cases and Floating Support, and Hillingdon has been granted funding for implementation of the IRIS program, which is really good because it's working with the primary care and using other routes to identify victims of domestic violence rather than just the traditional police and social care. And this is rated amber due to the rate being above the national average. And we don't have data which shows improvement, although we know of the initiatives that we are implementing. Hopefully, data always comes a few years later, so we'll keep an eye on that. Reducing homelessness. Now, on this, a majority of indicators are red, and this is why it's rated red. So our estimated rate of homelessness is 6.4 per thousand. That's the crude rate. England is at 4.2, but London was at 15.9. So there is something happening across London, and our work is mainly now focusing on actions to prioritize prevention of homelessness. For example, working by P3 for young people. And to prevent homelessness for young people, but also using some of the population health management approaches. We want to improve services to prevent homelessness. There are a number of actions which are highlighted on page 12. I wouldn't go through those, otherwise I will be here forever. Moving on to 3.3. Which is preventative care hypertension work stream. So priorities under these are integration, implementation of Fuller report and development of integrated neighborhood teams, and where hypertension was identified as a focus for preventative care work stream. And this is rated amber because again it's related to the data. Our rates for mortality from hypertensive diseases seems high, although it is old data from 2020 to 22. So let's see with the current initiatives where we get to. Hence it's amber. Should I just summarize?
What I was just going to say, Sheikha, is that I've obviously read the report. It's a very comprehensive report, and I guess from a health and wellbeing point of view, what I would like to know, what are the 2 or 3 areas that you think we really ought to be concerned about and to be focusing on? Because obviously I'm rag rating, any who works in the public sector, get familiar with rag rating, it becomes our way of operating. But are there 2 or 3 areas you think actually we ought to be concerned based on this information? What do we ought to be concerned about? What should we be focused on? Rather than having maybe a lengthy discussion on all the paper, what are the big knotty things that from a public health perspective you're advising us you really should be worried about this? We really need to improve in this area because it's focus.
Sure. Thank you, Chair. So a key development which is happening currently is the application of population health management program and its role in developing the integrated teams. So currently capacities, there are 3 members of staff who are based in public health, and they are 2 have been appointed, the 3rd will be appointed. So they will be working at utilization, so on a very data-led approach. So utilizing information which comes from WISIC and from Joint Strategic Needs Assessment in the future, utilizing that to tackle some of the wicked issues, the complex problems. And for that, capacity needs to be built of staff. So those skills in what are we looking at, what does data tell us, but which bits we are going to work on, and how we show improvement. And some of the public health skills in terms of what does the evidence tell us, and how do we prioritize which will be a good evidence-based initiative to implement in Hillingdon. So building the capacity of partners across. They started by looking at just the primary care and integrated neighbourhood teams, but also maybe in council, across health, social care, and third sector as well, building the capacity to use those population health management techniques to identify key sections of the populations on which we work, and also core 20+5 priorities.
So just having read the report, I guess I'd be keen to hear from other members of the committee. It seems to me that we've got three, what's leaping out here, where we don't do so well. I mean, we've got good approaches, we're doing well in areas, but homelessness, autism, tooth decay, it looks like we're shallowing, that we're not making progress. Are they the areas you'd point me to, or would you say you really should be focused on something completely different? Because I'm very familiar with the neighbourhood work and the population health stuff, and I know Eddie and colleagues in primary care has done a lot of work around hypertension and in other areas. Well, what else do you think, what should we have a laser view on? If I was going to focus in more detail, what are the 2-3 areas you think you need to be worried about this?
I think hypertension and obesity, homelessness.
Okay.
So those are the key areas.
Okay. That's really, really helpful. Can I just bring you in, Sandra? We just think about Sheik and then.
Thank you, and I agree that it's very comprehensive. What I think that if Kelly was here, she would agree, is that we need to perhaps see wider reporting on all of the indicators with primary care, etc. So socialising some of the outputs of what's happening in public health at the moment, so that it's not so standalone, and we're not coming with this report that's fresh information, as it were. So I think that there are I know there's lots of work going on in primary care and across our place-based arrangements that ties into this work. So I think one of the things that I would suggest, and will be suggesting with Kelly when she's back from leave, is that we find other reporting and monitoring mechanisms for this report. Kelly's recommending that we change the way in which we report this at the end of its life cycle, which will be in January 25. So we're kind of finishing off this particular set of targets, and actually it's a good opportunity to focus on those and drill down on those things that Sheik was talking about, that we have identified through population health management approaches. And I guess probably everybody in the room would say maybe a different 3 things that you asked for, but if you were asking me, I would definitely say homelessness is a project that isn't a public health responsibility and it's in isolation. It's a whole council responsibility and a whole system responsibility, and how we manage that, because we know that healthy homes are great for having healthy people. But then I would say let's focus on a good JSNA, good data, so that we can all monitor it really well. And the work that's happening with obesity and oral health in children in particular is making, I think, for the first time in a very long time, some good progress. So doubling down on that through the whole process will make a difference, and we can see that difference is starting to emerge.
Eddie.
Yeah, just to pick up on the piece around hypertension, and also the piece that Chika mentioned about time lags on data. So there's been a big emphasis on the detection and improving the prevalence rates of hypertension. But of course, if you're spending 18 months increasing your diagnosis of hypertension from 10% to 15%, that's not necessarily managing those people with hypertension, and then you've got to put in the management to bring that hypertension under control, and that's the thing that then prevents strokes and other disease. So you've got to be wary that within a whole, some of these things are 3-5 year cycles. So we've got to be careful not to jump onto the next priority before we've actually worked the previous priority right the way through the system. And I think hypertension is something we're doing really well in, but actually we're increasing demand on certain services at the moment because we're detecting a lot more, and we've actually got to bring the management of it under control. So there are quite long time cycles to what we're talking about within some of these priorities. So yeah, word of caution.
Okay.
Thank you, Chair. Thank you, Sheikha. I'm pleased to see that Hillingdon domestic abuse is in there because obviously, well, not obviously, but as you may be aware, that is under my chairmanship. So yes, we have made huge strides and it's recognised in the report. My concerns as Chair are that the referrals from health service still remains very low, and it's an unsung part of domestic abuse, how that mentally and physically affects people living with it, and I would like to see that a lot more. I'd like to be able to reflect that more in a health report, and so I suppose I'm asking for health primary care to participate more in that whole thing. You know, we should be asking people. I know it's difficult when you're going into a GP surgery and you've got 2 minutes, but I need to see how domestic abuse is affecting people's health, because like obesity, this is one thing that is getting worse. Nobody seems to be addressing what I would say is a national epidemic of domestic abuse. And in order to see the success of our services, I need to hear a lot more about how it's affecting people so that we can make a change at a higher level. Because at the moment it's only being looked at the physical or the mental abuse, not the fact that they may well be living in poor housing conditions and things like that. So I'd like to just ask that our health partners work along with us to get much more reporting on health. Thank you, Chair.
Sheikha, any of that you want to come back on, just in terms of, we've had a number of comments there.
Just taking the last one first. I worked on training for primary care ages ago on domestic violence, so I totally support that. And I think mental health, primary care clinicians regularly are in contact with women who experience domestic violence more than any other professionals. And identification is very important, and I hope the IRIS project will help towards that. And do you want me to respond to the hypertension comment as well? Yes, absolutely. I mean, increasing the uptake of health checks is going to put pressure on some services, because we are going to identify more people with diabetes, but in a good way, diabetes and high blood pressure with high cholesterol levels, and that's what we want to do, identify those people and put them on medication, and also on the area that we haven't been doing very well on is preventative interventions, which are linked to physical activity programs and obesity, but that is improving because we now have a Tier 2 obesity prevention weight management program, which is again hosted by the Confederation, and it's doing very well. Thank you.
Thank you, Sheikha. Any more questions before I just summarise what I think we're saying and then move to recommendations? No? Okay. So what I've heard is that we've received the report on year 1 and 2 of the health and wellbeing strategy. We're making good progress in some areas. There are other areas where we need to do better. And Councillor Palmer's highlighted the importance of the domestic abuse issues. We are coming to the end of the health and wellbeing cycle. I think what we're asking is the Director of Public Health to lead on the development of a refreshed health and wellbeing strategy based upon a new JSNA. Again, what I'm hearing, Sandra, is that actually the strategy needs to be more integrated. It needs to be joined up and more central to driving how we operate as a place partnership, and shouldn't just be seen, and I'm sort of overstating this, as an issue for public health and to deal with. It's got to be core to what we do. But what I'm also hearing in doing that from Eddie is that there has to be some continuity in that actually we're trying to make significant change to the health of the public, and that just doesn't happen in 6 or 12. It doesn't happen in NHS financial cycles, put it that way. So it's actually trying to do that, having some continuity, but integrating it more. Is that a fair summary of where we are? Okay. So if I summarise what the recommendations are, that we receive the report, we note the progress, we support and applaud the availability of health inequalities funding, which we're now deploying against a range of public health interventions. The recommendation is that we ask the Director of Public Health to lead on, not to do on her own, but to lead on a new health and wellbeing strategy based upon a revised JSNA, and that we receive subsequent reports according to the timeline which is set out in recommendation 4. Is that supported? Okay, thank you for that, and Sheikha, thank you for that, and please pass our thanks to Kelly as well for the work that she's done in this area in the public health team. That's my pleasure. Okay, I am going to move on, if I may, to the integrated health and care report, and I find myself of being in the place where I am Gary and Sean all in one. When the great aren't here, they're simply whoever's left standing must then pick it up, and it's me on this particular issue. So what I am going to do is take the report largely as read. I'm going to try and avoid talking about the BCF because they're 3 letters I would like to expunge, I guess, from my vocabulary on this one. But let me just take the context and the briefing on this. In terms of the key points to bring to the board's attention on this, which I do need some to do an overview on. So first of all, we were required to submit our BCF Quarter 1 template on the 29th of August. That was submitted. That was submitted through co-chairs action and Sandra's action on that, as delegated to us by the board. Principally, the key elements of that is around the discharge funding, and that is available to us. The point that Gary makes is that obviously we have a additional allocation of just under 934k in terms of the discharge funding. You'll see attached the appendix of the report where we are in terms of the proposals to spend that. There is still discussions ongoing between local authority, between place-based partners and hospital included, about how we best deploy that funding. But that is literally being worked up at the moment. But the focus of that is meant to be what we call P3, so the sort of pathway 3 funding, which is largely about people who are being admitted to long-term care and how we manage that. So that's the area that we're currently focusing on. We have some deadlines for reporting on the BCF spend. That is set out under Section 7 of the report, and what it's recommended is the sign-off of those templates in quarters 2, 3 and 4 that is delegated to the Corporate Director of Adult Social Care in consultation with Jane and myself as co-chairs of this committee and the Chair of Health Watch, Hillingdon. So that's one of the recommendations I'm doing so far. And then the other thing is around the responsibility for the day-to-day monitoring of the Better Care Fund sits with the BCF Core Officer Group, and the membership of that, apart from Sandra and myself and Gary and Richard and Sue from the ICB, we receive the detailed reports from that, and the request here simply is how much information does this board want to receive in terms of the deliberations of that group. At the moment, it comes through the report which Gary provides in the summary report. It's just checking with this board whether you are still happy that that is the correct level of detail, or whether you want further information. Always be careful what you ask for is my recommendation on these things. So those are the key issues. In terms of in terms of performance, what I would say, and there's a lengthy report there. If I was to summarise it for people, particularly in terms of our urgent and emergency care system, what we're seeing across Hillingdon is actually the number of A&E attendances generally has flatlined. It is broadly the same it has been in previous years. What has changed significantly is what we call the conversion rate. So that's the amount of people who come to ED and then subsequently are admitted as a result of going to ED. That has risen quite significantly, particularly over the latter part of the last financial year and the early part of this year. And what we have done is we have commissioned Brunel to do a piece of work around looking at why that we think that is. In other words, has the acuity of patients, so that's are patients iller than they have been in the past, to do a piece of research work just to analyse that. A lot of the work that we have been doing as a place partnership is how we work together at place to try and mitigate that. But from the data, that's what's happening. The number of people attending ED is broadly the same. It's just the conversion. The number who are admitted has risen significantly across Hillingdon, and trying to understand why that is quite important. The reason why we do have a bit of a track record sometimes of putting the wrong solution to a particular problem, and I think it's quite important that we understand that. So that's basically what Gary is saying in this particular report, and what Sean would have said had he been able to come today. So I'm going to switch off from presenter mode and go back into chair mode, if I may. Are there any questions on the report, with the caveat that if I don't know the answer, I will say I don't know the answer, and I will make sure we find the answer. Otherwise, I'm quite happy to make things up as we go along, which I think is not what we're trying to do in the context of this meeting. So, Jane.
Thank you. I don't have any questions, but I just would like to have some observations noted that we probably could do a lot more for our female patients there with the cancer screening. I noticed that's slipping and women aren't being served as well as they could be, so I don't have anything else to say on that. And then if I look on page 16 and 17, I can see two things. That one definitely relates to staff shortages, and one we're not too sure about. So if I take the education, health and care plan, I haven't got it. There's no explanation. Well, I would expect to see an explanation. And then if I look at the slippage on the care and support for adults with mental health challenges, I find the last sentence quite controversial, that the learning is the sentence about sufficient workforce to cover any staff absence. Well, if you've got a staff absence, I'm pretty sure the service won't be met. So I think there's a lot more we could say there, rather than not enough staff don't do the job. There's much more learning you can glean from the fact that if people aged over 65 with dementia aren't being served well, the learning from that will be greater than not enough staff. I won't quite say it's insulting, but it's not far off. I'm sorry to be blunt, but that's what I see it as. So I'm interested in, what we do, what's happening. If you haven't got enough staff, it's obvious that people aren't going to get the service that they're entitled to. So they're not questions, Chair, but you can hear I'm a bit disgruntled on a couple of occasions there.
And I think you're right to be disgruntled, Chair. I think generally, rather than being specific about particular lines on this, what I would expect when we put a report is that obviously if there's an underperformance, or you would expect to understand what the action is that goes along with that, and I think that's quite important. I think we have to expect as a board that there's a clear action if there's a deficit in it, and there aren't in some of these. So I think I would support that. Vanessa, I'm not going to put you on this box. It's not necessarily your services, but just in terms of the mental health and the memory services, can you enlighten us and give us some comments on that?
Thank you, Chair, and thank you, Jane. In terms of CNWL and the memory service, as far as I'm concerned, there aren't any major gaps. So I need to take this sentence back that's in this report and go back and see what that's referring to. Obviously, if we had any staff that were off either for sickness or for any other reason, then we would look to cover that with temporary staffing so that we had a full staff complement. And if there are gaps in services, those get escalated to me. So I will pick this up, and I'm happy to come back with maybe what this refers to, but I'll pick that up with the authors of the report.
Do you mind if I just interject there? It actually does say that locum support was in place, but it's still impacted on diagnosis. So what you're actually saying is that the staff are there and still you haven't got the... That's as I understand it. So greater explanation of that might serve you better.
Yes, I'll go back and check that out with the memory service in terms of capacity and demand.
Lynn.
Thank you, Keith. 2 points, if I may. Firstly, Health Watch has certainly seen a significant increase in the number of patients that are unhappy with the A&E and urgent care treatment services at Hillingdon. And as I'm sure you're aware, the CQC have recently visited unannounced to the UTC at Hillingdon, and we are waiting for some more formal feedback on that. But just going back to the 60% increase in conversion, that's a very large number. Do we know whether they are medical or surgical conversions? And is there any relationship to patients that have been waiting significant lengths of time for either medical or surgical intervention?
So I'll try and pick that up, though. Obviously the detail would normally come from Jason, who would be here. So one of the reasons, so the conversion rate hasn't jumped 60%. The conversion has jumped to 60% from an average of around 30 to 40%. So it's jumped around 20 percentage points. And the honest answer to that is principally it's patients awaiting medical intervention as opposed to surgical. But if you're saying, and why is that, Keith? We don't know the answer, which is why we've asked Brunel to actually look at that in terms of what the acuity are patients iller or not, and the challenge that we have, and if Jason was here, I'm sure he would say, because we changed over the old system that we had, the IT system, wasn't really able to tell us anything systematic about acuity of patients. The new system is better at doing that, but what it means is we can't necessarily compare this year to last year because we just end up with quite spurious numbers. So we've commissioned Brunel to do that piece of work over the next quarter, just to look at what that acuity is and what the driver is of that. Because until we have that data, we can't really be certain. Sandra.
I think it's a really important point in terms of understanding the acuity of those patients, because clearly a good proportion of those people will come to adult social care following their hospital admission, and we're seeing quite a significant rise in acuity, which is very difficult, as you say, to measure. And so the acuity of those patients and where they come from as a result of, and how long that's been. So for adult social care, that would have been in the last 18 months, 2 years. We've seen that steady increase in acuity. So any work with Brunel would be, jointly, would be really, really interesting.
That's helpful, Sandra. I mean, I will speak to it because what I talked to Brunel about was literally around the ED situation. But if it's impacting adult social care, then it may be worthwhile, actually, and more interesting for them to do that double piece of work, because it's quite easy to throw out a statement that says, well, the patient's supposed to be iller. But if I'm honest, what I'll be looking for is this: why are the patients in Hillingdon more ill than any other of the 7 North West London boroughs? So what is happening here? So I think we do have to lance this one. We do have to get some sense of a baseline which says either they are or they are. Devil.
Thank you, Chair. With this work group, Brunel, will they also be looking at things like what the length of stay was for the patients that were admitted, to how many were admitted for less than 1 day, for example, and they've been admitted in order to try and keep the flow through the ED rather than go and manage them in a different way with support at home or whatever? So, Patricia, if you're watching this, I do my best on your behalf. So what we know, with the reintroduction of the clinical decision unit at THH, the number of 0-day spells did increase. It also helped to improve flow, as you would expect that to do. But actually, length of stay as a place we do well on. We do well on our length of stay, and our discharge are probably the best in North West London in terms of what we do. So if your question is, we're looking for a range of indicators, aren't we, to indicate that there's an issue, there are some contradictory things there, which I think that's why we need to look at it, because you're absolutely right. I would expect the length of stay, or length of stay is actually coming down. We also know from work that we did as part of the place-based recovery plan, what we do know is that the acuity of patients at weekends who come to ED is lower than it is during the week. So there is an issue around Saturday and Sunday, particularly over 65s, where there are people at lower acuity levels who are coming to ED who wouldn't come during the week. So there's some interesting things about 7-day working there, which again we're trying to work through. But we do need to get to the bottom of it, because my worry is we tend to rush to solutions which aren't necessarily the solutions to the problems that we've got. Any other questions on that subject? Have I answered everything there, Lynn, that we got? Okay, thank you. Okay, so again, can I try and summarise what I think where we are on this one? So we're asked that the Health and Wellbeing Board approves the Q1 BCF reporting template, clearly in retrospect, from where we are. That we delegate authority to approve the Better Care Fund subsequent reporting templates to the Corporate Director of Adult Social Care and Health in consultation with the co-chairs of this board, and confirm the arrangements for the monitoring of and reporting on activity and spend against the agreed BCF plan outlined in the report. If you're happy with that, I'm looking for assent here. People are happy with that. What I would say, the caveat I would add to that, and if we can, Nikki, for the minute, what I've discussed with Gary and Sean is looking at this report is to look at whether actually we can change the format in terms of how we report the data, to make sure that we're focusing on the things that are really important and gives us the numbers. Sean was going to come today to talk about some thoughts that we had, but clearly he can't. But what would be helpful if for the next meeting, Nikki, we could schedule an agenda to talk about future dashboard and reporting for this particular area. It's a chance for us to review what we get and just decide whether we want some other data, which is just more helpful and more impactful.
for us. But again, we've got a straw person, Aunt Sally, whatever old-fashioned phrase you want, to share with you. But it would be good to get your feedback on what the board actually wants in terms of reporting. Okay, I think we're now on to, and you'll correct me if I'm wrong, Nikki, to the board planner and future agenda items. Is there anything on those? He says we've got agenda item 7 and appendix 1. We've got the forward planner with the suggestion I've just added to that, which I would suggest for November. Are there things which board members would like to focus on? And I think what we might want to do, and I'm making this up as I go along, James, so you please do. We might just like to think about whether we're getting the right agenda items coming to the Health and Wellbeing Board, in whether we're using the people's time here as well as we could do, and whether actually we might need to like to think about what we get and how we receive it going forward, given the move towards more place-based governance. So that might be worthy of a discussion, whether in the public or the private part. I'll leave that to colleagues to think through. I think it is good just to review what we do and how we do it. Would be helpful. Okie dokie. Right, let's move on. And I think, having lost my pen, no I haven't. So I think where we are now is, I think we've reached the end of the public part of the meeting. So what I would just like to do is to thank people for coming and for your contributions today. And could we just wait whilst, obviously, we close the public part of the meeting? Thank you.
Okay, let me just turn